My name is Dr. Michael Martino. I'm an ABEM certified emergency physician and peer-to-peer advisor for Ceribell. In honor of World Brain Day, I'd like to share with you a clinical case highlighting the utility of Ceribell in diagnosing, monitoring, and managing focal status epilepticus. This case of non-convulsive status epilepticus involved a patient who was 81 years old with Parkinson's, hypertension, and had colon cancer status post-resection. 3 weeks later, he presented to the ED for abnormal labs and urinary retention. BUN was 140, creatinine 18.2, and sodium 134. The patient was admitted and treated for obstructive neuropathy. On the next day, he developed new onset AFib with RVR and sepsis with fever 101.2. The patient was placed on broad spectrum antibiotics for left lower lobe pneumonia and UTI. However, later in the day, he had worsening mental status and then had a witnessed generalized seizure. The patient was treated with Keppra. BUN at that time was 53, creatinine 3.3, sodium 149. CT of the head was obtained, showed no edema or other findings. MRI of the brain showed abnormal signal in the left mesial temporal lobe, so the patient was started on acyclovir. CSF was then obtained and was negative for evidence of meningitis, encephalitis, or autoimmune disease. 2 days later, there was again concern for seizures, this time due to right-sided weakness, myoclonus, and altered mental status. Since non-convulsive seizure was considered, Ceribell was applied and confirmed with 100% seizure burden. The patient was treated with lorazepam, which you can see time-stamped here, and resolved the initial seizure down to 0% seizure burden, but then quickly had recurrent seizures which were refractory to Keppra, lacosamide, further lorazepam, and valproic acid infusion. The decision was made then to intubate the patient, and his seizures resolved on propofol and midazolam. The patient remained intubated for a week and subsequently was extubated and transferred to the medical floor. But 2 days later, a rapid response was called, and the patient again appeared to be in status epilepticus. The patient was intubated again, and then his status was changed to DNR, and he ultimately succumbed to his disease. Ceribell was very important in this case. Let's look at the impact it provided. First, it empowered the medical team to diagnose focal status epilepticus even before it progressed to generalized status. This was pivotal since conventional EEG was not available at the time, and since the patient went on to fail response to first or even second line anti-seizure medications. Ceribell also provided real-time monitoring of ongoing refractory status epilepticus and a time-stamped record of response or lack thereof to aggressive medical management, guiding critical interventions. Finally, Ceribell monitoring confirmed that the patient's seizure activity was indeed squelched and not ongoing while intubated and maintained on propofol. Ceribell is a powerful tool for clinicians providing critical diagnostic and therapeutic response information. I hope you will consider how Ceribell might impact your patients and empower your approach to focal status epilepticus. Thank you for your attention and for the care that you provide. I wish you all a healthy World Brain Day and look forward to speaking with you again soon.